last MCQ session we had some problem with specialized radiographic techniques. I will take classes on specialized imaging techniques, and then if you have any difficulty we will go to basics of radiology. Okay? We will be talking about tomography, CBCT, MRI, USG, all of this. So what is the basic principle of tomography? What is tomography? Any idea? Sectioning or slices. You are seeing a three-dimensional object at various slices. Say you are seeing the imaging of this finger. It is not the finger that you are seeing at the tip. You are seeing finger at the section of 1 mm, at the section of 2 mm, at the section of 3 mm. And when your image is being seen, you will scroll the mouse so that next section of images are being displayed. So that is the basic principle of tomography. In conventional tomography, you have nothing to do with systems or anything. But whereas in computer tomography, it is associated with your computer technology. So that is your basic difference between a regular tomography and a computer tomography. Basically, they are sections or slices viewing of your structures. All right. Okay. Computer tomography, all you have is computers and tomographic principles. You would have seen this machine, right? The huge circle that you're seeing around is called as a gantry, and the patient is lying down on a bed, which is called as a patient couch. The patient will go inside and outside of the gantry. Okay? Inside the gantry, what you have are the detectors and the X-ray source. And based on the detector X-ray source, we had lot of developments of your CT machine. There were 5 generations of your CT machine. As and when the time was evolving, the CT generators were also evolving. And this was an MCQ question, if you remember. The heating capacity was 1 to 4 mHu were in case of your CT. Okay. And I told you, you have an X-ray source. The X-ray source is the same source that you are using in an IOPA machine. How you have a cathode, you have an anode, X-ray production happens. The X-ray source is basically the same. But your detectors, where you have, instead of a photographic film that you are using in an IOPA film, you will have some solid state detectors or gas detectors or scintillation detectors. All of these can be used separately or used in combination. These are the detectors which will absorb the X-ray attenuation passing from the X-ray source through the patient. It will be absorbed by the detectors, and from the detectors it is going to go into the computer console. Okay? And the methods to reconstruct image. Your computer will not read it as nose, eyes, ears. Your computer will read it as digital numbers like 001, 101, the binary system. So it will read it as numbers, and these numbers put together will be read as ear, nose by us. And each number will represent one grayscale. Say you have a grayscale from 0 to 256. So, okay, so you have 255, totally 256 numbers, totally 256 grayscales you have, and each grayscale represents one value. And that value, if you say, like for example, if I am seeing this box from the outside alone, okay, and this outside is having a color, this is called as a pixel. What you are seeing on the TV screen is a pixel, alright, but actually you are seeing the attenuation of the entire thickness of the box. What you are seeing on the outside is the attenuation of the entire thickness of this box. It is called as a voxel. Okay, it will have a width, it will have a height, and it will have a depth. So when you are seeing a CT image on the screen, it is basically all the attenuation of one voxel. One voxel actually represents one thickness of your tissue. If your tissue is, say, suppose 3 mm thick, what pixel that you are seeing outside on the screen is actually the attenuation, meaning the combination of all the voxel grayscales which is being displayed as a pixel outside. This is the basic principle that you are seeing in a CT. Okay, and the computer, to do all these pixelations, voxelations, to bring down all the grayscales, it uses certain algorithms and flowcharts. They are computer technologies that you are using, and the one which is used in CT is filtered back projection and FELCAM reconstruction. These two words you just need to remember for your MCQ purpose. What they are is not necessary. Okay, they are basically computer algorithm techniques which will actually read your tissue attenuation factors to bring out as a visible image. what the computer understands is not a visible image. What the computer understands are in numerical forms, and what you are actually seeing is through this reconstruction techniques. They are basically softwares that is being used in the computer. Okay? And this was also an MCQ. I told you the patient goes inside the gantry and comes out of the gantry. The rate at which the patient is going inside the gantry, that is called as a pitch. The table travel per X-ray tube rotation divided by the image thickness. Image thickness is nothing but you can image the patient at 1 mm thickness, you can image the patient at 10 mm thickness. How much you want you can decide before actually subjecting the patient inside. If you are going to put 1 mm thickness, you will get a very minimal slices. At every 1 mm thickness, you will have the X-ray photons passing through. But the problem is high radiation exposure. The advantage with this technique is when you are doing a 3D reconstruction, you will have the best image possible. But if you are going to do a 10 mm thickness, the remaining information between the 10 mm is not so sufficient. So when you are reconstructing as a 3D image, the image will be blurred. It will not be as apt as a 1 mm thickness. The advantage of doing a 10 mm thickness is that you will have a less exposure. Okay. If you are going to see the margins of a tumor, then you will definitely have to go for a 1 mm thickness. If you are going to see margins of a cyst, then it's enough if you go for a 10 mm thickness. You know it is pretty well defined and it is not going to be spreading everywhere. So a 10 mm thickness is fine. Understood? These were the generations I was talking about. Okay. The first, second, third. As the machine was evolution happened, you had generations of your CT machine also. The significance of which is given behind. Okay. The first generation is nothing but there was only a thin pencil-like beam, and that was hitting on the detector at one point. The first image is a first generation thing. So from the source of X-ray is the one which is black on the opposite side of the patient, and you had one panel of detectors, and at every point it had to go and expose the patient. When this happened, your scanning time increases. Alright, the thin pencil beam, the scanning time was increasing. For every section it had to go one pencil beam, shift, one pencil beam, shift. So by the time one entire section was being created, it took almost 5 minutes. Okay. And the next one, second generation, it was a pencil beam, but the detectors were more. It was not just a flat detector, the number of detectors were more. In the third generation, you had a fan-shaped beam, but still the detectors were not sufficient enough. In the fourth generation, is the generation which we are using now, you have a ring of detectors, okay? You have fan-shaped beam, and you will have 1 or 2 X-ray sources. When this happens, your scanning time was reduced to almost 30 seconds per section, okay? And after that, your fifth generation was developed, which was an electron beam. It was not just a normal pencil beam or a fan-shaped beam, it was an electron beam, and that was used for moving objects like your lungs, anything which has moving organs. Those kind of organs were being imaged with your electron beam 5th generation CT. But what we are currently using in medical CT is only a 4th generation CT. Okay. And what is spiral CT is nothing but, I told you, patient moves inside, one section is being imaged. Moves one more inside, one more section is being imaged. In spiral CT, especially used for heart imaging and your lung imaging, as the patient is moving inside, this is also rotating. So that is called as a spiral CT. This will save your time very much less, and apart from this, it will also image any moving objects with greater efficiency. Okay. So I told you about the slice thickness, right? As much as only 1 mm is possible. 1 mm to maximum of 6 mm, maximum is not a problem. 1 mm is the minimum possible, whereas in CBCT 0.3 mm is the minimum possible section thickness. And you have something called as CT numbers. I was talking to you about the pixel and voxel, right? And I told you each pixel has got a grayscale value and it has a number. Yes, and that number is varies between -1000 to +1000. And they are basically nothing but attenuation of all your grayscale values. Okay, your CT number is nothing but attenuation of all your grayscale values. All that put together which is visible outside on your screen, that is your CT number. Okay, basically they are grayscale densities. And these are possible MCQ questions. They will give you -1000 and it is a Hounsfield unit for what? Or they will ask Hounsfield unit of air is what? Values will be confusing. And you must be very careful of minus and plus. Okay. and how they have had a reference value for this is 0 is considered as a reference value. The CT machine is said to have some water, and the water is being taken as a baseline value. Anything below that it goes as minus, it goes to air. Anything above that water goes as plus, it goes up to bone. And something is not written in this, you have a cementum and enamel which is plus 2000 to plus 3000. It is denser than bone. Okay. Your blood, your soft tissues, your muscles all will come under soft tissue. Somewhere range between 40 to 60, and these values are subjected to change. So when they are asking a question like plus 50, it must strike you that it is going to be a soft tissue. You need not expect the same Hounsfield unit values everywhere. It is not like standard, each book's values differ. This is just book values from White and Farrow. Okay. So if you are going to see air, like where do you see air in body? Air. Sinuses, that is going to appear black. Okay. If you are seeing bone and soft tissue is possible in CT. Okay, but not as much as a soft tissue as you see in MRI, but to certain extent you can see bone and soft tissue in CT. So soft tissues like bone, you will have plus 1000 means it will be white. Okay, it will be hyperdense. And if you see air, it will be black areas. And somewhere in between the grey areas is what they are describing here. They have a side, they have lot of, it's basically software stuffs. So they have options in the side of which one is called as Hounsfield unit. You click on that and then click on the tissue where you want it to, you want to know the Hounsfield unit. It will show you the number based on which you will decide what kind of tissue you are clicking at. This is one MCQ question. Okay. Your axial section, your coronal section. Okay. These are the what you have is axial, coronal, and sagittal. And based on all these things, you will have to do a 3D reconstruction. These are the basic 4 images of a CT image. And indications and contraindications, how they will ask you is the following are indications of CT except. This will be one question. Nothing to teach in this as such. Alright. And contraindications is not there like much in CT. Probably they will not do for pediatric patients. But as such, there is no absolute contraindication for CT. And the advantage is probably you will have both your hard and soft tissues. Again, advantage and disadvantage, the following are advantages of CT except. The following are disadvantages of CT except. You have to be very careful of that except line, based on which your answers are subjected to change. And the major problem is your metallic artifacts. If you are seeing a metal object on an IOPA, it will be appearing as a radio opaque structure. But if you are seeing it in a CT, you will have streak artifacts, like something, like a brush border appearance. So that is a major disadvantage of your CT. It will obstruct your imaging quality. And I was talking to you about CT, and there's something about the CBCT also. Okay, the CT is nothing but, I told you they have pixel and voxel, yes, but the voxel thickness is a rectangular thickness. Okay, when I'm trying to reconstruct it, it will be a disproportionate voxel. But in case of cone beam CT, it's an isometric voxel. It's like a box. It's not like a rectangle. When I'm trying to rearrange it, it will become like your cube. The cube which you play, Rubik's cube, right? So when I'm trying to rearrange the CBCT pixels and voxels, it will come as a perfect cube. So when this happens, in my conventional CT, I will have to apply separate algorithms and flowcharts so as to bring the 3D reconstruction. Whereas in CBCT, the primary image which the computer is giving me only will be a 3D image. That is because of the voxels. You understood? Clear? Confusing? See, when it's a rectangular voxel, the computer is not able to produce a cube, correct? When it is a rectangle, you can't produce a cube. So, you will have to take a axial image, you will have to take a sagittal image, you will have to take a coronal image, and then only using all that, it is making a 3D reconstruction. So, to do a 3D reconstruction in CT, it is time consuming and it is not the primary image. The primary image which you are getting is either a coronal, axial or a sagittal. Whereas in case of your cone beam CT, your voxels are isometric voxels. It's like a box. So when it is rearranging, it will come like a Rubik's cube. So it is very easy for the computer to make it as a 3D reconstruction. So when the computer is displaying you an image, it will come as axial, coronal, sagittal, 3D. You need not sit and do the reconstruction part. The computer will do, that will be a primary image itself. This will need special algorithms, that does not need special algorithms. The basic reason why it is so, the software is designed that this is rectangular voxel, that is your isometric voxel. Okay? And the type of detectors is different. Here you have a fan shaped beam. Here is a fan shaped beam and a ring of detectors. There it is a cone shaped beam. It will be like a cone. So when that cone is going, it will image the entire volume. Imagine that cone is here. It is going to image the entire thickness of it. Whereas in CT I told you section by section. That is because it's a fan shaped beam and it will go and section by section with the fan. But whereas in case of your cone, it's a cone shaped beam sitting on a flat panel detector, which the detector here is flat. It's not circular. Okay. When that happens, that entire thickness of that cone will be imaged as one thickness of the volume of tissue. It does not do sectioning. That tomographic principle exactly is not working there. One whole volume is being imaged in case of CBCT. Your scanning time goes down, your working time also goes down in CBCT. And the exposure factors is likely to be one more MCQ question. What is for CT, what is for CBCT? Major disadvantage with CBCT is that it will not image any soft tissue at all. It will just appear like black. It will not show any soft tissue at all in CBCT. Whereas in case of CT, you have something called as, I can see it in abdomen window, bony window, soft tissue window, lung window, pelvic window. So there are so many windows through which I can see the same CBCT image. So it will enable me to see both the hard tissue and the soft tissue. Have you seen scrolling of CT? You have not seen scrolling of CT in your medical wherever you go? You will see the sections, like they will scroll and then it will go to next section, next section. So that is your window level. Okay, and they move, the grayness changes, right? It will become light grey, dark grey. That is your window width. Okay, the degree of densities will be your window width, and the thickness at which you are seeing is your window level. These are some terminologies in CT. All right. Okay. How it happens in a CBCT? How image acquisition happens in a CBCT? The question can be, the steps in CBCT are the following except, or it will be the order in which it happens. Step 1, step 2, step 3, they will give data acquisition, primary reconstruction, secondary reconstruction, or they will change the order and give you. You will have to find what is the correct sequence of image creation process. This can be one MCQ. The first is data acquisition. I told you, right? It's a cone shaped beam and it's a flat panel detector. So the entire thickness is got in one rotation. It is not like CT that they do so many rotations. In one rotation, it will go around the patient like a OPG machine. It will go around the patient like an OPG machine. It has a cone shaped beam of the X-ray source. It will hit on a flat panel detector. So when you see a cone hitting on a flat panel detector, you will have a round image. Eventually, you will have a round image. So that is your data acquisition. It is taking the data from the patient, hitting on the flat panel detector. This is step 1. Okay. Primary reconstruction. Now it is hit on the detector. The detector is taking the information to the computer. When that happens, I told you, computer does not understand ear, nose, mouth. So it is taking it in terms of pixels and voxels, which is obviously isometric. I told you, once it arranges, it will arrange like a Rubik's cube. Okay. So this is your second step, which is called as primary reconstruction. The acquired data is being assigned as pixels and voxels, and it is rearranged as a cube. Then the third step is your secondary multiplanar reconstruction, meaning I told you, being isometric voxels, it does not require any special algorithms. So by itself, it is going to produce my coronal, axial, sagittal images. The sagittal on top, axial here, and coronal below. Okay. So it is already, the voxels are isometric. So by itself, without any algorithms, we need not take separate axial section, coronal section, sagittal section like how we are taking in a CT. One single image we have taken, computer is dividing it into 3 sections. So final image when you are getting in CBCT is going to appear like this. The first one is your panoramic image. The one below is your tangential, cross-sectional, your axial view, and your 3-dimensional view. Alright. So this will be your final image. Whereas in case of CT, how will it come? It will probably come like the axial image below. and then you will have to sit and shoot the patient again for a coronal section. And sagittal is probably your scout image. So you already have a scout image of your sagittal. You will have to take an axial image, you will have to take a coronal image, and you will have to sit and reconstruct, and then only you will get the 3D image in the final step. Whereas in CBCT, after I shoot, immediately this page will come. Correct? So this is the basic difference between a CT and a CBCT. Your advantage of your CBCT is probably only your cost. It's much less expensive than that of your CT, and it occupies less space. Yes. And your radiation dose, that is important MCQ. 52 microsieverts to maximum of 1025 microsieverts if you're going to do a full maxillofacial skeleton. It cannot be done more than your sinus, it cannot be done more than your cervical spine. Okay, your field of view is only that much. You can either do only maxilla, only mandible, but you cannot do anything more than that. It's basically a head and neck imaging technique. And the disadvantage is, yes, no soft tissue contrast, and it's got a lot of image noise. If you see a CBCT image, it will not be as clear as a CT image. Yes, CT is doing section by section, so it is very clear, but this is doing as one full volume. This is just what that I told you, right? If you're going to do a 10 mm thickness, it is not going to be clear. It's almost like that. CBCT is doing the entire thickness, so the clarity will be much lesser than that of a CT. And the resolution, that is also an MCQ question, 0.4 to 0.125 mm. This chapter is available in White and Farrow 6th edition, okay, and it is also available in Eric Waite's 4th edition. This chapter as such is there. These are new chapters added this year on textbooks. So its applications is endodontics, periodontics. You can see nice workation involvements. Surgery, the major use, you do a nerve tracing and do a you have this ABC of your impaction, right? So it is best used for that. And then for implant assessment, you can see the height, you can see the width, you can see the approximity to your anatomical structures. So there is an image acquisition has been done. You measure the height and width, you see the proximity of anatomical structures, and you do a nerve tracing if it's going to be a mandible, and then you see for the angulation of implant. This is the implant assessment using CBCT. Steps of implant assessment using CBCT. So that was a CT and CBCT. Any doubts? It looks like it's a vague topic. Just see the MCQ parts of it. Okay, your sub-millimeter resolution, your pixels and voxels, and terminologies like CT number, and what are all the Hounsfield units, and what is a window width, what is a window level, what is a pitch. All this is possible MCQ questions. Alright? I'll move? Okay. Sorry? You can, brain will not be imaged. Only up to the, no, the imaging, the field of view is only up to the maxillary sinus. Maximum it will go up to the orbit. The maximum FOV is 15 by 8. 15 by 8 I think is available at Aarti Scales, Rajan Dental Institute. They are the ones who have the maximum FOV. FOV is nothing but field of view. This much only can be imaged. Up to your hyoid bone, okay, up to your hyoid bone below, and up to your lower border of your orbit, only that is a field of view. And your right and left is up to your TMJ, not beyond that. Okay, so it's like not beyond that, not beyond this. This is a field of view. Only this much can be imaged in any CBCT. Like some colleges are having only maxilla, only mandible, or only the jaws will be visible. You can't even see your mandibular nerve. So that is a field of view of about 8 by 5. So small, medium, large. These are the three field of views available. Maximum is large, least is small. Small will not be useful. Small is as equal as having a IOPA with you. Small is bad for use, medium is okay to use, large is the best to use. You can see your airway, this airway can be assessed. Airway assessing, they do it for general anesthesia purpose. If your airway there's a block, they will not do general anesthesia. Okay, and then you can see deviated nasal septum can be seen. Okay, and your maxillary sinus proximity can be seen for sinus lift procedures. Okay, mandibular nerve tracing can be done. So apart from your dental work, these are the other structures that you can see, other applications of a CBCT. Okay. Any doubts? Window width and window level. See, when you are scrolling that CT, next section is going left. That is your window level. Okay, and when you scroll again, but you only the color changes, the grayness. It's either too dark or too light. Same level, but the degree of darkness that will change. That is your window width. The thickness, the grayness at which you are looking at an image. Any other doubts? No. So these are possible MCQ questions. Your CT number, Hounsfield units, and they'll give a Hounsfield unit and ask what tissue it is. And the author who has invented CT? That was an easy question. That was there as an MCQ question. I was talking about Hounsfield unit. Godfrey Hounsfield is the one who discovered CT. Okay. Wood. Yeah. Right? Okay. Magnetic resonance imaging. Magnetic, so it has magnets. Resonance is basically a physical term, physics. Okay. And using these two concepts, you are doing an imaging technique. This is one of the non-ionizing, okay, non-penetrating kind of imaging technique. So it is going to use basically magnetic power. I told you human body has got lot of water. 70% of human body is only water, and water formula is H2O, which means hydrogen ions is the basic principle behind using of magnets. So when you are subjecting a patient to magnet, the hydrogen ions which is present in the patient will get aligned according to the magnet. It will become, initially it will become haphazard. Initially in a normal human being, when we are sitting like this, hydrogen ions will be haphazardly arranged in the body. When you are placing such a patient in a magnetic field, it will get oriented, aligned, it will be in a proper manner, either in the spin up or the spin down. Hydrogen atom, you consider it as a small pieces of ions or magnets. It will be either in the north pole or in the south pole. You have a magnet, you will have a north pole, south pole, correct? So it will be, north pole will be facing up or the north pole will be facing down. Okay, the one which is facing up is called as a spin up, and the one which is facing down is called as a spin down. Say there are 50 spin ups and 40 spin downs, 40 will get cancelled, 10 spin ups will remain. That will be remaining in the patient. Now when this is only when the patient is placed inside the magnet. Next step is you will send in an RF pulse. That is, you have a button, you just switch on the machine, you have a button, you click on that, and RF pulse will be sent to the patient. So whatever excited spin up is happening, that will get excited by this RF signal, pass through the patient, and you will switch off the RF signal. When you switch off the RF signal, the energy which is being gained from the RF signal will be released, and that energy which is released is being captured by your detectors, and that detectors will be transferring the information to the computer, and similar images of your coronal axial sagittal will be displayed on the MRI. The major problem with MRI is it has got very powerful magnet, so you must be very careful before going inside the MRI machine. Alright, this is one. Second is, if you are going to have metallic objects, pacemakers, you cannot go inside your MRI machine. If you go inside, your pacemaker is likely to get disabled when you are getting into the magnetic field. Okay? If you are going to wear any clips, brain clips, surgical stents, you are likely to get stuck to the MRI also. So you are having a lot of difficulties with the MRI. Apart from this, if you are going to be a claustrophobic, you have fear of closed spaces, you can definitely not go inside the MRI. And if you have some hearing deficit, some kind of a tinnitus kind of a problem, there will be huge noise when you are going inside the MRI machine. And it is not like CT where only one portion of you is going inside. It will be like a tunnel. So much of sound inside a small tunnel. If you are having a hearing problem, you will go deaf. So that much of sound will be there. Generally, they will give you ear mufflers to wear to go inside that. Okay, so noise problem, claustrophobic problem, and your surgical clips and stents problem is all present in MRI. But this is one of the techniques which is using non-ionizing radiation, so considered to be safe in pregnant women and kids. Alright? Okay. I told you about the steps of before placing, during placement, RF signal placement, and then after placement. So the same thing I am going to tell you with terminologies. Alright? Whatever I have told you is in simple manner. I wanted you to understand how an MRI works. Now whatever I have told you, I will give you imaging terminologies for the same. Alright? Okay. The first is, I told you when you are placing the patient inside the magnet, you will have spin up and spin down. So together it is called as longitudinal magnetization. And I told you it is either in the spin up or in the spin down. But how did it come? It came from a randomly placed hydrogen atom. So that energy transfer which is happening when it is randomly placed to spin up or randomly placed to spin down, when that moves, that energy transfer is called as resonance. And hydrogen ions basically precess means rotate. It's like the earth. Apart from rotating by itself, it also rotates the sun, correct? So that spinning of protons is called as your precession. You will have a tilted axis and you will have a spinning. It will spin around itself and spin around the earth. So it is going to spin around its point and also around the body. So when that happens, it is called as precession. And the frequency at which it precess is called as precession frequency or Larmor frequency. The spinning is called as precession and the rate at which it is spinning is called as precession frequency. I gave you a formula for precession frequency or Larmor frequency. F is equal to YBO, where Y is your, is it? That is also an MCQ question. What is the determinant of Y, what is the determinant of B? Gyromagnetic ratio and your magnetic field strength in Tesla. That is the formula, the product of gyromagnetic ratio and your magnetic field strength in units of Tesla together forms your Larmor frequency. Okay. So then you have net magnetization vector. NMV is net magnetization vector. I told you it is going to cancel the effects. Plus and minus is cancelling. But after it cancels, the entire combined effect of a spin up and spin down is called as your net magnetization vector. All this happens when you are just placing the patient inside the magnet. You can switch off your RF pulse, but you cannot switch off the magnet. You understand? Yes. So the first 5 steps are the steps occurring when you are placing the patient inside a magnet. Clear? Any doubts? Okay, I am going to the next step. I am switching on the RF pulse. I am applying the radio frequency pulse. Okay? There is an RF antenna coil which is going to produce the RF pulse, and it is producing the RF pulse which is proportionate to the Larmor frequency. There is fixed values for Larmor frequencies, so proportionate to that you are applying an RF pulse through the RF antenna coil. I told you so far longitudinal magnetization was happening, spin up and spin down. Now you will have the transverse magnetization happening. Alright? When that happens, your hydrogen atoms, that is your protons, will rotate to 90 degree perpendicular to your longitudinal magnetization. Longitudinal magnetization is your y-axis. Okay? Transverse magnetization is your x-axis. Now all the protons are in the y-axis. When I am applying an RF pulse, it will go at a 90 degree and it will go in a longitudinal magnetization. Alright? And this flipping is called as a RF pulse or flip angle of 90 degree. And when it is going in longitudinal alignment only, you can actually capture the image. When it is in the transverse, you cannot capture the image. Okay, now it is gone like this. Now it is in the longitudinal magnetization. When this, it's in the transverse magnetization. When this happens, the overall concentration of the hydrogen atoms in that particular area will be calculated. Okay. Yeah, that is called as proton density. The computer will calculate the overall concentration of hydrogen nuclei in the tissue when it is going in the transverse magnetization. That was step 2. In step 2, there are only 2 steps. Flip angle of 90 degree, transverse magnetization and proton density. Now I am switching off the RF pulse. This is the third step and the last step. Okay. Once I switch on the switch off the RF pulse, it will all flip back to the normal state. So from the transverse, it will go back to your longitudinal. When that happens, you will have some energy lost. Correct? Some energy will be produced and it is lost, and that is called as a free induction BA. You have something called as T1 weighted images and T2 weighted images. T1 weighted images is looking at the anatomy and T2 weighted images is looking at the pathology. Okay. So I told you, you are switching off the RF pulse, the transverse all is becoming longitudinal. When that recovery happens, the rate at which that recovery happens is called as T1. The rate at which your recovery of longitudinal magnetization from transverse it is going to longitudinal, the rate at which it happens is called as T1 weighted image. And the amount of loss of your transverse magnetization, I told you transverse is lost, that is why you are getting longitudinal. The amount that is lost of your transverse magnetization is called as T2 weighted image. The rate at which it is becoming longitudinal is your T1 and the amount of loss that has happened in your transverse is your T2 weighted image. In your MRI, your fluids is going to appear dark in a T1 weighted image and it will appear bright in a T2 weighted image. How the appearances of your MRI? It's either dark or light. It is what? Like how you are seeing in a radiograph, radiolucent, radio opaque, it is not like that. In T1, what is radiolucent will appear radio opaque. In T2, what is radio opaque will appear radiolucent. You understood? Basically, fluids is supposed to appear radiolucent, correct? In your T1 weighted image, I told you it is a normal anatomy. Normal anatomy and all will get dark off. So, fluid is going to appear dark in your T1 weighted image. And in T2 weighted image, your fluid, same fluids, it will appear bright. Okay? And there is something called as repetition time, TR. That is nothing but time between the pulses of RF waves that you are sending. RF waves are sent proportional to your Larmor frequency. And the time between the pulses, each pulse that you are sending of your RF waves is your repetition time. And the response which you are getting from the patient is your echo time, TE. When both TR and TE is short, it is a T1 weighted image. When both are long, it is a T2 weighted image. That is nothing but, echo time is nothing but the time between sending of the RF signal and receiving of your MR image. You will find as though you are able to understand everything. The problem is you will have to remember the terminologies. It is completely understandable, but you will have to understand and remember the terminologies. Okay. So those are your 3 steps in your MR imaging. Placing the patient in the magnet, sending of RF pulse, switching of the RF pulse. Under each you have, first step you have 5 steps, second step you have 2 steps, and the last step you have 4 steps. Clear? You remember this? This is entire MR imaging. Not given in any textbook, so perhaps you could write it down. This PPT is with sir, you can collect it. Entire radiology is there in that. About some 500 slides is there. Okay. See, T1 weighted image is basically anatomy. Okay. In that you will have the echo time and your repetition time both are short because it's anatomy. When that is short, obviously the fluids will appear dark. When it is long, it is going to appear white. It is basically your computer technology only. Everything is computer. Why it is black, why it is light, adukku reason kadiyadu. When your TR and TE is short, it will become dark. When your TR and TE is long, it will appear white. Avladha concept. If I start why, then that class will go for 2 hours. For MCQ purpose, they will ask you maximum only this much. Your TR and TE is short. So what will the fluid appear like? Fluid, they will probably ask CSF fluid, something like that. Your MCQ will be in that manner. Then they will tell you your TR and TE is long, how will your CSF fluid appear on MRI? They'll either give dark, black, grey, dark grey, and the madri codes they'll tend to confuse you. So you must know what will happen. T1 is for anatomy, T2 is for pathology. TR is your repetition time, TE is your echo time. And they'll ask you formula for Larmor frequency or precessional frequency. Both means the same. Larmor frequency or the precessional frequency means the same. The rate at which the precession happens is called as your Larmor frequency. That formula is F is equal to YBO. That is important. And Tesla is the unit of magnet. Like we say kilograms and grams. So Tesla is the unit of magnet. What we are using in medical imaging is like 1.5 Tesla. Clear? You go through these slides again at home separately. Again you will have doubts. You will go through it again. Alright? So, do you remember one important indication of MRI? I have told you. I told you that is possible only in MRI and no other imaging technique. Perineural invasion. Okay, so in which tumor you have perineural invasion? Okay. Apart from that, for your tumor staging, your TMG assessment is the most important imaging in your MRI. You can see the articular disc. Articular disc again is your, can be seen only in MRI. It cannot be seen in any other imaging technique. You have functional imagings also, but it will appear only as bright spots and dark spots, but you cannot view an articular disc in any other imaging technique. Just like perineural invasion, articular disc can be seen only in MRI. Alright. Advantages and disadvantages. The question is only like this. Following are advantages except, following are disadvantages except. Nothing great in this. Ultrasound, okay, invented by Marie Curie and Jacques Curie. Just the names. This is the screen that you are seeing. This is the operator console, and you see this round thing. That is where they are going to alter your next views. And this is the transducer that you see on the side. And transducers, you have high frequency and low frequency. High frequency is to view the superficial structures. Low frequency is to view the deeper structures. It is like, inversely proportional. Okay. High frequency, you can see the superficial most structures. Low frequency, you can see the deeper most structures. It's inversely proportional. Basically, this transducer serves both as a transmitter and a transreceiver. However it sends the signal, same way only it is going to receive the signal also. And basically they are sound waves. And MCQs from this was, what is the frequency of sound that a human can hear? What is the frequency of sound from USG? Those were the MCQ questions. You can go back and read. Alright. And so basically it is going to send sound waves to the tissues. Alright. And at each tissue you have an impedance. And some amount is lost and some amount passes through the next tissue. This is how it begins. And you will have that last tissue that it is hitting on. Only to some depth it can penetrate. It will not penetrate the bone. So only to some depth of the tissue it is going to penetrate, and beyond that it is not going to penetrate. It will start reflecting back. So whatever signal is being reflecting back, it will again pass through the same tissues and come back to your transducer. And through that it is going to the computer, and it is visible as grayscale images. Alright. So apart from this, you have something called as a color Doppler. Color Doppler is nothing but to assess the flow in that particular tissue. It's especially used for your vascular lesions like hemangioma, aneurysm, okay, and arteriovenous malformations. It will detect the kind of flow, whether it's an arterial flow or a venous flow. It will detect the velocity of flow, based on which you will have images appearing. So that is your color Doppler or Doppler phenomenon. Doppler is the one who invented that. That is where the name is given. You can also see some calcifications in your USG. Alright. calcification, if you see in a USG, like for example, you can see a silolith, alright. Silolith, you can image salivary gland in USG, that is not a big deal. USG is basically for soft tissue imaging. You can see a salivary gland, that is not a big deal, but you can also see a silolith inside the salivary gland and how it is going to appear. You are standing in front of the sun, so you will appear very bright, correct, when you are standing in front of the sun, but there will be a shadow cast behind you. So that is exactly how a silolith happens. When you are hitting the sound waves on the silolith will appear very bright, and behind the silolith it is going to appear dark. Same shadowing principle. It is called as hyperechoic shadow, hyperechoic intensity with post-acoustic shadowing. Hyperechoic intensity with post-acoustic shadowing. Your silolith will appear bright, so it is called as hyperechoic, and the shadow which you are seeing behind the silolith is your post-acoustic shadowing. That is exactly same principle when happens when you are standing right in front of the sun. You can compare right and left side in USG. On the same screen, you can split the screen and compare two sides. Alright? You can see TMJs on that. You can see your blood flows in that. You can see your arterial branches in that. You can see your salivary glands in that. Your muscles, your masseter muscle assessment, all that can be done in USG. Your only disadvantage is it's a real-time imaging. So the operator, the doctor has to be there present all the time. It's not like you have taken the image, you give it to the radiologist and they give an interpretation like how it happens in CT MRI. Okay, it's completely operator dependent, and this is one of the real-time imaging. All the other imaging techniques are not real-time imaging. Alright, they are just 3D imagings or 2D imagings. USG is one of the real-time imaging. Apart from this, you have thermography. That is also a real-time imaging. You have nuclear imaging, that is also a real-time imaging. You have TMJ arthrography, that is also a real-time imaging. Real-time imaging is nothing but apart from the 3 dimension, the 4th dimension of time is also being implicated. TMJ arthrography, nuclear imaging, USG, all these are real-time imaging. And this is the second non-invasive imaging. The first one was MRI, doesn't use any ionization X-rays. Second is your USG. If they are going to ask you about non-invasive and non-ionizing techniques are following except, then you can write it as MRI and USG. No other technique comes under non-ionizing and non-penetrating. Then you are going to the nuclear medicine. The most common that you are using is your technetium. You have iodine, krypton, all the others are available, but technetium is the one which is being commonly used. And we do a bone scanning to assess the growth of the bone, how much of bone is growing, the growth spurts assessment, okay, and fracture assessment. All this can, fracture in the sense long term, the fracture is being present for a long time but it is not healing, all those kinds of conditions you will use bone scanning. Bone metastasis, when there is a full body, you have a CA, multiple CA, you will have to check for bony metastasis. For all these conditions you are going to use a bone scanning. How it is used is you will have to subject the patient to 10 to 15 millicuries of your technetium 99M. You will inject that into the patient and give a waiting period of about 2 to 3 hours, and after that you will place the patient under a gamma camera, and whichever bone you need, that will be imaged. And when you are seeing that, you will see as bright spots and dark spots. You know, it's called as cold spots and hot spots. Hot spots are areas of activity. Cold spots are area of inactivity. Say suppose you have a fresh fracture, that area will appear hot. Okay, if it's going to be a healing fracture, it will start appearing cold. So you're going to see in trauma, TMJ changes, osteomyelitis, skeletal metastasis. These are the applications of bone scanning. And Gamma camera is nothing but I told you like we have we have CT gantries, right? So something like that only a gamma camera will also be. You will have to place the patient inside the gamma camera. It will be like a gantry and it will do its work. Okay. Basically, it will. Technetium is a radioactive material. So based on its decay, the gamma will absorb the decay and tell you the value. All right. Positron emission tomography. What is a positron? It's a subatomic particle of proton. So that is a concept here. And this was an MCQ question. Do you remember? The material used in PET scan, 18-FDGP, 18-F-fluoro-2-deoxyglucose. This is the positron that you are using in positron emission tomography. It's basically a radionucleotide product. And I told you there gamma camera, right, for bone scanning. What here you are using is a PET camera. And there in CT I told you it is made up of solid crystals, gas crystals, scintillation materials. Here they are using bismuth germanate scintillation crystals. The material in which the PET camera detectors are made is that. So these are MCQ questions. How it happens is not important for us, but basic MCQ questions you will just have to know. Same thing, you will have to administer this radionuclide for the patient, give a waiting hour for about 2 to 3 hours and then place the patient in the PET scanner. Okay. Basically your photons will be emitted. Once you give the radionucleotide, it will break down and it will release photons, and these photons will pass through the patient and it will hit on the detectors which is around the patient, and that will be transferred to the computer. The most important thing is this is a functional imaging technique. All nuclear imaging techniques are the functional imaging techniques. Your PET and the previous bone scanning, they are all functional imaging. Basically, you can divide your imaging technique into anatomical imaging and functional imaging. Your CT, MRI, USG comes under your anatomical imaging. Your nuclear imaging like your bone scanning and this positron emission tomography, your salivary scintigraphy, your bone scintigraphy, all this comes under your functional imaging. When you are combining your anatomical imaging and your functional imaging put together is called as fusion imaging. So the major use is PET CT. Some machines are designed to take both PET and CT in one machine, but otherwise you will have to place the patient in PET scanner, take an imaging and then transfer the patient to the CT scanner and then take an imaging and fuse both the images. Basically for tumor assessment, lymph node metastasis and distance metastasis, secondary tumors, for all this you will have to use positron emission tomography. All these are methods of cancer imaging. Xylography, and you have contrast studies, alright, CT contrast, MRI contrast, it's there in your MCQs. What is a contrast material used in CT, your urography, your contrast material in MRI, contrast material in UST, contrast material in xylography. All these are MCQ questions. And contraindications of xylography is an MCQ question. Your acute infections, iodine sensitivity, and patient going for thyroid tests, and all these will be your contraindications. Procedures, it is pre-filling phase, filling phase and post-evacuation or your emptying phase. You will have to detect the orifice and then enlarge the orifice with a lacrimal probe, inject the dye into the lacrimal, through the lacrimal probe, you dilate it and then inject it through the duct, and then you take a scout image before the dye giving. During the dye giving you take one image, and after 5 minutes, after all the dye has been drained, you take a post image. These will be the 3 images that you are seeing. What's important MCQ can be, the following are fat soluble contrast images excel. The following are water soluble images excel. The names of these contrast agents will be given in Nilima Malik. You have a chapter on xylography. The exact names, okay, Indian names will be given in that textbook. Just go through it. What we are using here is only renographin, urographin. Generally we use water soluble because fat soluble tends to be painful. But water soluble contrast is not as good as your fat soluble contrast. Contrast in fat soluble is much better. That will be your MCQ question. What are the following are fat soluble contrast materials except. The following are water soluble contrast materials except. This is also one kind of MCQ question. So Sjogren syndrome, what is the appearance in xylography? Snowstorm appearance. Xylolith, it will appear like a radio opaque mass with distal obstruction. Distal to the duct, it will be obstructed, correct? Proximal, it will be okay, but distal to the duct, it will be obstructed. That is one. Xylodochitis has a sausage link appearance. So these are possible MCQ questions. Sausage, you know what a sausage is, right? So sausage link appearance in case of xylodochitis. Snowstorm appearance in Sjogren syndrome. Sialadenitis, dots or blebs of contrast material is seen in sialadenitis. Neoplasm. Neoplasm. You want to try? Ball in hand appearance. Ball in hand appearance in neoplasm. Filling defects in strictures. Intrinsic tumor, extrinsic tumor, you have ball in hand appearance. Sausage link appearance in xylodochitis. Normal parotid gland appearance is tree in winter appearance. Normal submandibular gland appearance is bush in winter appearance. Any doubts so far?